60-year-old man presents with acute onset of ptosis, and on lifting the eyelid physically, we find the eyeball is deviated outwards and downwards, and on looking at the pupil is dilated. So what's your diagnosis? Yes, it's a case of complete third nerve palsy. Before understanding the third nerve examination, let's understand the extraocular muscles and their innervation. So basically there are four rectus muscles: the superior rectus, medial rectus, inferior rectus and lateral rectus, and two oblique muscles, that is superior oblique and inferior oblique muscle. Now out of these things, the lateral rectus muscle is supplied by the sixth cranial nerve and superior oblique is supplied by fourth cranial nerve. Rest all the muscles, that is the three recti muscles, superior rectus, medial rectus, inferior rectus and inferior oblique, are supplied by third cranial nerve. The mnemonic to remember this is LR6, that is lateral rectus is supplied by sixth cranial nerve, and SO4, that is superior oblique is supplied by fourth cranial nerve. LR6, SO4. Apart from these muscles, third cranial nerve also supplies the constrictor pupillary muscle. So once the light falls onto the pupil, because of the action of the constrictor pupillae muscle, the pupil will constrict. Third nerve also supplies another muscle called as levator palpebrae superioris. Now this muscle elevates the upper eyelid. Okay, when the muscle is intact, person will be able to open the eye normally like this. When the third nerve is affected and when the levator palpebrae superioris becomes weak, person will end up having ptosis. So this is again image where person is having complete ptosis. This is because of the weakness of the levator palpebrae superioris muscle, which is supplied by the third nerve. So patient comes to us like this. Once we open the eyelid with the fingers, we see that the pupil is dilated. If you compare the affected side pupil and the normal side pupil here, we notice that on the affected side the pupil is very large. This is because of the loss of function of constrictor pupillary muscle. Because of this, the pupil gets dilated and it is fixed, as in there is no direct or indirect light reflex present in this pupil. And when we physically lift the eyelid, we also notice that the eyeball is resting in the outward and downward direction, unlike the normal eye where the eyeball is resting in the center. Now why does this happen? This happens because of the unopposed action of the lateral rectus. The action of lateral rectus is abduction of the eyeball. Now this lateral rectus is supplied by the sixth cranial nerve. Since the sixth cranial nerve is intact, lateral rectus is intact, the unopposed action of this lateral rectus leads to abduction of the eyeball. Along with that, there is also superior oblique, which is supplied by fourth cranial nerve. Again, this is intact. The action of superior oblique is depression when the eye is abducted. That is why again the unopposed action of lateral rectus and superior oblique will cause the eyeball to rest in the outward and downward direction, like the way it is seen in the picture. Now when we examine the extraocular movements, before that we need to know what is the action. So the superior rectus, action of superior rectus is elevation of the eye, that is the eyeball will move up. Since this is supplied by third nerve, the eyeball cannot elevate. Inferior rectus, the action is depression of the eye. Again, this is lost in third nerve palsy. The medial rectus, the action of this muscle is adduction of the eye. Since this is also supplied by third nerve, adduction also is lost in the affected eye. So the net action the net eyeball movement which is present is only abduction because of the intact sixth cranial nerve. Thank you.